Why don't we go with Linda B? Linda, are you ready?
Yes.
Okay,
Perfect. Great. Hello, it's a pleasure joining these friends for after these beautiful talks, and I've learned a lot in the last hour. I'm going to try to transition from some of the excellent tips on anatomy and on the imaging to practical monitoring during the operating room for jugular foramen and specifically the lower cranial nerves. As has, several speakers have already delineated, the cranial nerves in the jugular foramen are quite complex, both in terms of their sensitivity and function, as well as their interlaced network to pathologies in this region. And when we think about monitoring, the general two buckets of monitoring, which is monitoring the integrity of function versus mapping, looking for a nerve or a part of the brain in terms of its function, including EMGs and other such things, are the two buckets of intraoperative neuromonitoring that we think about. The broad categories of monitoring and mapping throughout the brain and brainstem include sensory, motor, cranial nerve, and reflex monitoring, and likewise for mapping, surface versus deep mapping. Today, I'll focus on some of the specific modalities that relate to the lower cranial nerves and therefore the jugular foramen. The traditional monitoring modalities that we won't talk about as much, but of course have a lot of overlap with pathologies in this region because jugular foramen tumors or lesions often transgress beyond just the jugular foramen and compress the surrounding brainstem. So these are often used in conjunction with the subsequent modalities I'll mention, including, of course, sensory, somatosensory evoked potentials, motor evoked potentials, and EMGs. With respect to the lower cranial nerves, common modalities include glossopharyngeal nerve monitoring, which is usually electrodes put into the soft palate. This is probably the least specific of all lower cranial nerves. And I would say if there is one nerve to not monitor, it would be this, mostly because of the overlap of sensory dermatomes or functions between the vagus nerve and the ninth nerve. So this is probably the least reliable of all the possible nerves. The vagus nerve is a very powerful nerve to monitor, both in terms of its motor as well as its sensory function. The most common modality that monitors the vagus nerve is probably a NIM tube, an electrode embedded in the endotracheal tube that then is inserted at the level of the vocal cords under direct visualization to allow for monitoring. There are also electrodes that we can put into an oral gastric tube that can be put adjacent to the endotracheal tube and also indirectly monitor vocal cord responses. In comparison to this embedded tube, the cricothyroid muscle is an easily accessible muscle that relates to the vagus nerve that's on the surface and can be monitored either through subdermal electrodes or insulated electrodes just with palpation alone. The accessory nerve is also a very powerful nerve to monitor, not only because it's so easy to have easy to test for the reliability of the monitoring because it's so easily seen, and any touch of the accessory nerve for anyone working the jugular foramen will cause a shrug of the shoulder. So you can feel it in the operative field and know if your neuromonitoring is accurate or at least sensitive and serve as a sanity check for the placement of electrodes and the monitoring modalities. The hypoglossal nerve can be monitored in several ways, given the complexity of the muscles in the tongue. I won't go into the details, but if one is planning on doing cortical bulbar motor evoked potentials, in other words, simulating the cortical surface and measuring the recording from the tongue, then placing the insulated electrodes more laterally along the tongue is probably the most sensitive of all the possible modalities for monitoring hypoglossal function, such as for hypoglossal schwannomas and other such tumors. But altogether, in the recent 2 decades, there has been emerging interest in not only monitoring these functions, as we classically have done through EMG, through seeing the nerve and touching it and seeing the trigger back response, but also indirectly through firing a stimulus through the scalp and stimulating the cortex and seeing if we can record that through the distal muscle recordings along the tongue, the vocal cord, the shoulders, and so on. And cortical bulbar motor potentials are most commonly and most famously applied for the facial nerve, but increasingly have been applied for a number of other muscles throughout the face, including cranial nerves 10, 11, and 12. And the experience so far with these worldwide, which has only been published in about 80 papers, less than a quarter of which focus on lower cranial nerves, so the lower cranial nerves is really more recent experience, I would say in the last 10 years or so. But in essence, to summarize some of the lessons learned, although there are many different stimulation paradigms, electrode types, and ways of stimulating this, but in essence, what most of the experience, as well as ours, have shown that the stimulation montage on top of the scalp can be stimulated in what's called interhemispheric, meaning the anode is stimulated on one side and the cathode is on the other side of the hemisphere. And that works well for lower cranial nerves, corticobulbar motor vocal potentials. It does not work as well for facial nerve, corticobulbar motor vocal potentials versus hemispheric stimulation, where the anode and the cathode are both placed on the same side of the head, which works well as a kind of a scalp electrode montage for all motor cranial nerves. A more tight clustering of these electrodes on the head for corticobulbar motor vocal potentials is more effective than more distributed clustering. And for us, about a 3 centimeter square serves as an optimal kind of grid for placement of the anodes and electrodes when thinking about corticobulbar motor vocal potentials. And the use of insulated electrodes in general for any motor cranial nerve sort of output is more reliable than subdermal electrodes for recording. And so that can be placed on the trapezius, on the tongue, and on the cricothyroid. In even more recent years, the thought of reflexes as a continuous monitor for intrinsic circuits have gained a lot of traction. And specifically for the lower cranial nerve, the most popular that has been really first developed in the head and neck and ENT literature around 2017 and really refined in the recent 7-8 years or so is that of laryngeal adductor reflex. This has appeal for several reasons. One is that it allows for both afferent and efferent monitoring of the vagus nerve. In other words, one can, because of the drawing upon the reflex arc of the vagus nerve, if you stimulate motor on one side, send that reflex through the lower medulla and come out the other side, you can test kind of both the motor and sensory function, as opposed to sending the motor signal on the other side and detecting the afferent kind of sensation on the ipsilateral side. So this serves as a really powerful tool to test both motor and sensory function in one continuously or as necessary in the background. So how do we put that together in practical terms, and when do we use what types of function? Well, this is a straightforward example of a lower cranial nerve sternoma extending into the jugular foramen, as we already heard from several lectures, including Kantaro's beautiful example of one of these tumors. This is a 59-year-old man who presented with unsteadiness and headaches and had very good swallow and voice function pre-op. Confirming excellent function prior to surgery is probably the single best indicator of good function following surgery. So in a case like this, for me, this is earlier on, but before we had refined kind of corticobulbar motor vocal potentials for lower cranial nerves. I would do somatosensory vocal potentials, motors for the medulla being compressed, bears for the superior extension, monitoring cranial nerve 7 for the superior extension, cranial nerve 10 for using a NIM tube, laryngeal adductor reflex to look for that intrinsic circuit around the medulla, as well as background monitoring of the 10th nerve, 11 and 12. These days, we would also include corticobulbar motor vocal potentials for 10, 11, and 12, which can be fairly sensitive. And so in this case, with a dominant sigmoid sinus and jugular bulb on the operative side, there's a small sliver of residual within the depth of the jugular foramen that I left to preserve all of his cranial nerve functions, and yet mild hoarseness in the first month or two post-op, but normal taste and normal swallow. And by 3 months and subsequently post-op, had completely normal voice, swallow, and hearing, face, and all other nerve function. So it's an example of having preserved function, being able to guide, when to stop in these cases with a presumed benign pathology. In comparison, a tumor like this, which is a 38-year-old woman who presented with left neck pain for several years and radiographic progression of this lesion that was initially missed and clearly invades, spans above, below the foramen magnum into the cervical kind of region at the occipital condyle, expands and erodes into this calcified lesion of the left jugular foramen. In this particular case, preservation of the lower cranial nerves becomes much more fraught. And so for me, pursuing a transmastoid transcondylar approach, although I did extensive monitoring of both somatosensory and motor evocal potentials, bears, but the focus really is on EMG, not only of 7 as a control up above because of this intradural cystic and component, but also of 10 using a NIM tube, 11, 12 laryngeal adductor reflex to look for that circuit, and cortical bulbar motor evocal potentials for 7, 10, 11, and 12. In this particular case, we had about 70% loss of cranial nerve 11 and 12 of cortical bulbar motor evocal potentials, which is not perhaps surprising given the stuckness of this calcific tumor in that region. And post-op, early post-op, she actually had excellent function, but by 2 weeks, she developed more overt lower cranial nerve deficits, including difficulty turning her tongue to the left and more of a hoarse voice and partially compensated swallow. So although I was able to achieve a gross total resection in terms of bony and soft tissue landmarks, but she does have lower cranial nerve deficits that are corresponding to both our monitoring responses and the risks of this region. Beyond lesions in the jugular foramen, whether primary or secondary, there are these sort of nerve monitoring can also be important adjuncts in adjacent sort of tumors and pathologies. This is an example of a 29-year-old who actually presented with initial dysarthria, swallowing dysfunction, as well as weakness. And she is a young lady with neurofibromatosis 2, which had both bilateral tumors. One side was removed, and it was really growth of the second-sided tumor, both meningiomas and progressive schwannoma, that led to these lower cranial nerve deficits over time. And so for her, already having a contralateral vocal cord paralysis from other tumors and ependymoma history, preservation of the ipsilateral, meaning the right-sided lower cranial nerves, became paramount in her surgery for this, and monitoring all of the brainstem reflexes that focus on the lower cranial nerve, including laryngeal adductor reflex, trigeminal hypoglossal reflex, as well as the EMGs for the lower cranial nerve, really became keen. And starting from within a day or two post-op, she had improved swallow and voice compared to immediately pre-op in this case. So in my mind, the ability of monitoring for nerves that transverse the jugular foramen and the lower cranial nerves are important, not only of pathologies in this region, but also of adjacent pathologies, both in the skull base as well as in the brainstem itself. So I hope that these are increasing tools that you might apply in your daily practice and experiment with to see how they might perform for you. Thanks so much.
Thank you, Linda. Is there any question for Linda?